So performing CT angiography is really part of a diagnostic workup to evaluate patients with chest pain or symptoms suggestive of chest pain that you really don't know where they're coming from. It's very useful for diagnosis as well as for risk stratification. And I think in many patients it is the test of choice because it not only provides the information about whether there is obstructive coronary disease or not, which would make one then need to decide whether or not to go to the catheterization lab and stenting or revascularization. But it also provides a great deal of information about the presence of atherosclerotic plaque. And in many patients, or in fact most patients, there is more plaque than there is obstructive coronary disease. In fact, in the PROMISE trial, over half of patients had non-obstructive plaque, and only about 10% had obstructive coronary disease. So it was those sort of 2/3 of patients who don't need to go to the cath lab because they don't need a stent, they don't have a tight enough lesion, but they have plaque that needs very aggressive secondary prevention, or at least that I treat those patients with very aggressive secondary prevention. We don't right now have any trials about what to do with those patients. Now, of course, the kicker is in some of those patients with intermediate lesions, the 50 or 60% lesions, some of those will be hemodynamically significant even though they're not tight. And of course, in those with the 70, 80% lesions, some of those will not be hemodynamically significant in spite of being tight or stenotic. And for this, I use fractional flow reserve as a post hoc analysis of the CT images to help guide me whether or not there is obstruction to flow in those cases or not. And if there is both an intermediate or higher grade stenosis and an FFR CT under 0.8, I send that patient for revascularization, obviously PCI, CABG, depending upon the anatomy. If there is a tight lesion but the FFR is greater than 0.8, so no indication of physiologic significance, I think that patient can be handled medically. Of course, we need a lot more data to support that care algorithm, prospective data. That's just my approach to these patients. So to decide what test is a gold standard or not depends upon what information you want to derive from it. So if you want to know the percent stenosis of a coronary artery, what we usually consider as a gold standard for coronary disease, then you need either an invasive angiogram or increasingly a CT, non-invasive angiogram. Now, CT angiography has only been around, good multi-slice CT, for about 10 years, so the technology is still evolving very rapidly. I think it will continue to evolve and continue to have increased spatial and temporal resolution, reduced radiation, and will increasingly become relied upon as a diagnostic test. Other forms of non-invasive testing, which include functional testing or stress testing, are in their own way a gold standard. There is no better way to know what somebody's functional capacity is than to get them on a treadmill and see how fast and how far they can walk, what workload can be done. They're also better at detecting ischemia, of course, than angiography, because angiography is purely an anatomic measure. So some non-invasive measures that detect ischemia, SPECT, MPI, stress echocardiography, less accurately stress ECG, are perhaps a better gold standard for ischemia or physiologic significance than the anatomic data. And then there are emerging tests like CT perfusion, PET-CT, CT-FFR that promise in the future, hopefully, to deliver both of those types of information, and I think those will become the go-to test, the holy grail, if you will, for non-invasive testing.